I'm Tom McLellan, presently retired, but I've been a career researcher in the addiction treatment and policy field for about 40 years. I worked at the University of Pennsylvania, and I had my own research institute, treatment research institute. And I'm very pleased to be here because I see this as a place that is the next generation of not just addiction, but behavioral health treatment.
Thank you. Thank you.
It has the advantage of being true.
I'm really excited to have you. You and I have already had a discussion earlier today, which was really interesting, and I enjoyed it a lot, and I have tons more questions. But let's start from the beginning. What got you started in this work? How did you find your way into this career?
So, like so many other people who are in the addiction field, I stumbled into it. I'm sure, as a literate, intelligent person, you must have read my PhD thesis on learning in the cockroach, crayfish, goldfish, and it was compulsory reading almost everywhere. Anyway, armed with that kind of a background, and having just gotten out of the Army, I looked around for something, and surprise, surprise, there was not much interest in hiring somebody with who had an interest and a background in animal learning. So I drew a circle around the place that I was living and looked for places, and that included insurance sales and everything else. And one of the places was the Coatesville Veterans Administration Medical Center, a mere 20 miles away. So I went down there and asked for a job. And they said, well, we don't really have any jobs for somebody with your background. Now, we do have this thing called a program evaluator for a brand new thing called a drug dependence treatment program.
Wow.
And I said, yeah, I could do that, not knowing anything. And I remember to this moment, the first time I walked into the program, and there was a whole bunch of guys exactly like me, my age, recently out of the military, easy to talk to, compelling stories, and nobody knew anything. But the person who knew the least was me. And so it was a real love affair. I got involved in it, and fundamental questions about what do you want treatment to do? If it were effective, what would you want it to do? You want to, cure cavities and never have take a drug again for the rest of your life? Or do you just want people to go to work? What do you want? What would be effective? So for the next 40 years, I pursued that. And I had the very distinct advantage of having been supported by government grants. And I did a review, and I've had 125 government grants in my life. That's more than my fair share. And it wasn't all me, it was all my colleagues. Okay, that's a long answer to a short question.
Well, no, it's perfect. So I'm interested in how your career sort of unfolded. What types of things were questions that arose out of questions? Because I'm sure that's sort of what it looked like, right? Trying to find these answers, asking these questions, and I'm sure tons more questions came up. Yeah. What was that journey like between then and here we are now on this couch today?
Well, it was the mid-1970s. And at the time, while drug addiction was very poorly understood, there were only a handful of treatment programs around. Something important politically happened, which was returning Vietnam-era veterans were coming back with opioid problems. And college kids were having drug problems. And the reason that was important was it was impossible even for somebody, a drug warrior like Richard Nixon, to say, let's lock those people up. You can't lock up veterans. So they had to do something, and frankly, nobody knew what to do. Mm-hmm. So they created the National Institute on Alcoholism and Alcohol Abuse. They created the National Institute on Drug Abuse, and with it, a research portfolio. And we had the tremendous liberty to begin to ask questions. What should you do? What would be effective? How would you move the needle? How many programs do you need? I mean, fundamental things. So I was frankly right in the middle of it, and working for the Veterans Administration initially. The Veterans Administration was a league leader. That was their guys, and we drew from the meager literature that was available, but most people made it up, and that made a job for me to be the guy to evaluate the latest, greatest, shiniest thing that came by. So therapeutic communities, family therapy, psychotherapy, supportive expressive psychotherapy for addiction. Who'd have thought? Well, if the federal government's going to give you money to ask the question, let's do it. The emergence of medications, methadone, vilified from the very outset, just awful. Yet, the research kept showing people properly medicated and maintained did reduce their symptoms, did improve their health, did stop crime and improve social welfare. And so that's how it went. And I had a terrific career with a whole bunch of really smart people. And then everything changed. At this point, I was an expert. By this point, I had probably written 150 publications. I was being cited. I was going up the academic, rungs, and I was an expert in the addiction field. And then my son became addicted. And I sorry, I didn't expect this. I emphasized that I was an expert, and I was surrounded by experts. And I emphasize this because it was terrifying for me. I did not know what to do. Simple question. Where do you send your kid for treatment? What do you want him to get? I didn't know the answer, and maybe I mentioned I was an expert. Yeah. So how's a bus driver? How's a school teacher? How's a congressman answer the same question? And why was that question so hard to get? If you had asked me where to go to college, I'd have had an informed opinion. How to buy a lawnmower, I'd have had an informed opinion. But it was a critical one. And it was at that moment where I realized that lots of the research that I had been doing, though useful, valuable, certainly made me a living, wasn't going anywhere. It wasn't informing policy, and it wasn't, even more importantly, informing fundamental decisions that people had to make. So with that, and with $12,000 that I borrowed, I started a little institute called the Treatment Research Institute. And 25 years later, we went for 25 years and we tried to answer these basically, we thought of ourselves not so much as researchers, but research translators. To try to translate findings into practical treatments that could be applied in a reasonable budget, that could be replicated, that had robust results, that gave a demanding public what they needed, and gave policymakers what they needed. So that went along, and then while another moment in time when my eldest son was in treatment, for addiction and doing very well. My youngest son died of an overdose. And once again, you get, it gives you not only the personal tragedy, so many people have had this. It makes you ask a really fundamental question: what the hell are you doing? And months later, I was asked to join the Obama administration. I was originally asked to be the drug czar, and I said, I can't do that. I don't know anything about interdiction and, policing Caribbean waters for marijuana smuggling. I didn't know any of that. And so they came back and they said, well, how about if we get somebody who does know all about that, and you be the deputy, and you'll be co-equal. I said, yeah, I'll do that. I thought it was a sign from God. And that was another interesting chapter. And I think it's important. I get questions all the time from people who want to go into policy positions. I think you said today,
yeah.
I want to get into policy. Well, it's important. When I served, I was part of the cabinet, and there was nobody, certainly not me, who had ever had any course or anything in policy. What brings you to Washington in policy is expertise in an area that the country needs. So I say that as something of hope. If you do well in agriculture or defense or health, you are the kind of person that's important in policy. There are people who know the mechanism of government, but they don't know what provides value.
Right.
And so I think I was very honored to serve at that time with that president and that cabinet, and at a time when healthcare reform was happening.
Yeah.
And that's another sort of an interesting, I guess I'm going on too long here, am I?
No, I mean, I have another question, but keep going.
So it was an interesting time. Healthcare reform was supposed to not reduce healthcare costs. That's impossible at a time when the country was aging and all that. But it was supposed to reduce the rate at which healthcare costs were going up, so-called bending the curve. And so everybody was digging around, trying to find money, etc. I was brand new on my, I was a real fish out of water. I was brand new, and here I am at a desk in the White House, and nobody was talking about addiction at all. And so I said, I think there ought to be a part for addiction in this. And so I did what a researcher does. You go to the library and you dig out a couple of sets of facts and all that. And I looked at the costs of addressing addiction properly, and I made a graph of it. And two, I looked at the reasonable, I thought a conservative estimate of the savings that could be achieved if addiction were properly recognized, treated, etc. I made up two graphs, put on a piece of paper, and because I was in the White House, sent it to everybody in the White House. If you don't know, the White House is not just three guys, it's 380 people.
Yeah.
Office management, budget, everything. And it went to everybody. And at this point, I wasn't even Senate confirmed, so you just don't do that. Hours later, the then director of Office and Management and Budget said, "Who are you? And, would you come over here?" Because I had said proper treatment of addiction could save $300 billion in healthcare costs. The actual figure from the research that I had shown was like 350 billion, but I was afraid of the figure, so I rounded down to be conservative. So I go into this guy's office, and everybody's there, and he says, Everybody who walks in this office says, if you give me $1, I'll save you $5. They're always wrong. You actually got it wrong. You could actually save even more than your estimate. Why, when we looked at it, it was over $350 billion. So I, of course, immediately went into a pitch about this is why you have to include this in healthcare reform and parity and all that. And let's get some support for that. He says, you're in. We're looking for $50 million in savings. You're going to offer $200-300 billion. You're in. And that was like one of the kind of signal moments that you get in your career. Yeah. Right place, right time. Very unplanned. Yeah. And but then I said, this is not the kind of life I want to lead. Government it's a privilege to serve, but I don't have the temperament for it. And so I got out. And that's the end of my story. That's too long a story, I'm sorry.
No, it's not too long a story. So we've been working at this as a community, as a treatment community for a long time, as you have talked about. Yeah. And I mean, I've been in the field only for a little while, and I haven't seen too many places getting it right. We've been trying. What do we do? I know this is probably going to launch into another long conversation, but what do we do? What do you think we do?
Well, to be completely presumptuous, I think there are a lot of good answers. First of all, the reason you're getting it wrong is because of the way addiction has been thought about and addiction treatment has been structured and financed in this country. Until very recently, addiction was a sin. It was the sign of bad protoplasm, poor parenting, just low character, moral decay. These are not my made-up words. These are in all kinds of regulations. And as a sin, it fell very properly. Oh, and character disorder. And as that, it fell into the control of the criminal justice system. Keep drugs out of the country, arrest people that do it, arrest your way out of these sins. I mean, it's not crazy. And oh, by the way, we all know addicted people commit all manner of sin. So it wasn't a crazy idea, and there wasn't any science. And so they set up 15,000 addiction treatment programs in just early 70s. Jerome Jaffe was appointed by Richard Nixon as a special drug czar. And because healthcare wanted nothing to do with addiction, and doctors weren't being trained and were getting it wrong left and right, and were prescribing substances were actually addicting people, and I'm talking in the 70s, not recently, they decided we'll make addiction organizationally and financially separate from it. We'll set up places and they'll do their thing, and we political box checked, everybody's happy. Well, they got it wrong. They well intended, I can understand the whole thing, but they got it wrong. Fixed amount of treatment to come in and correct a fundamental character disorder, because that's the way it was considered. Yeah. All right, fast forward decades later, you now know something about genes, you know something about brain imaging, you know something about neurochemistry, and I'll be damned. It turns out addiction is a chronic illness. Not my opinion, it's a fact, it's a chronic illness. And so here we are now realizing that like diabetes, hypertension, asthma, chronic pain, all kinds of other things that are properly learned about in medical and nursing and social work school, that are properly reimbursed and treated in continuous care with monitoring and management, individualized treatment plans. That's how you treat a chronic illness. And here we have this system that has nothing to do with the healthcare system. It doesn't share information. It doesn't share budget. It doesn't share personnel, mostly, geographically usually segregated. And they're still doing things. Even the people who now realize it, they're still handicapped by the old financing, the old acute care model of treatment. Yeah. And it simply cannot work. It never could. It's a miracle, and a miracle that is mostly attributable to continuing care in the form of AA and NA, that anybody ever does get better. So I'm quite hopeful that the lessons that we've learned from the treatment of chronic illness, monitoring, management, team treatment, proactive care, equipping a patient and family to self-manage their illness, because you can't cure them. You can't cure diabetes or hypertension, but you can manage them. Those lessons, I think, are going to translate into addiction. And it turns out that we've got a lot to teach chronic illness, because it turns out that people with the same illness getting together to change their environments and support each other and train families can really manage a chronic illness very, very well, given the right opportunities. Yeah. So I think it's exciting time ahead, and I think it's an exciting opportunity for APN.
Well, thank you so much. Hopefully we'll have many more conversations. This one we're going to have to
shorter ones, though,
wrap up. No, longer. We're on a time crunch here, but we don't have to be forever. I really appreciate it.
Well, I'm sorry
Thank you. This was wonderful. Thank you so much.